Welcome to our video on pediatric GI diseases. Let's begin. In this lecture, we will cover Meckel diverticulum, Hirschsprung disease, and necrotizing enterocolitis. Here is an overview slide of the topics we are going to discuss for Meckel diverticulum. A Meckel diverticulum is a true congenital diverticulum in the terminal ileum. A true diverticulum means that it contains all the layers of the GI wall: mucosa, submucosa, muscularis propria, and serosa. A Meckel diverticulum is the most common congenital GI tract anomaly. It may contain heterotopic acid-secreting gastric mucosa or pancreatic tissue. A Meckel diverticulum is caused by incomplete resorption of the proximal vitelline duct, which is also known as the omphalomesenteric duct. Here is the illustration showing a Meckel diverticulum. During the fetal period of life, a vitelline duct, also known as the omphalomesenteric duct, connects the ileum to the navel. Normally, the vitelline duct should completely obliterate by the time of birth. If the proximal part of the vitelline duct does not obliterate, the patient develops a Meckel diverticulum. A Meckel diverticulum is most commonly asymptomatic. If it's symptomatic, then it can present with right lower quadrant pain because the Meckel diverticulum is located in the ileum. Hematochezia, or melena, can occur due to bleeding secondary to the presence of heterotopic gastric mucosa. A Meckel diverticulum can act as a lead point and lead to intussusception. Diagnosis of Meckel diverticulum is established by technetium pertechnetate scan, also known as a Meckel scan. Let's explain the normal and abnormal findings of a Meckel scan. In a healthy patient, the signal should come only from the stomach. In the patient with a Meckel diverticulum, the signal comes from both stomach and terminal ileum. Signal coming from the terminal ileum corresponds to the Meckel diverticulum. Here is what a Meckel scan looks like. Please note that the dark signal comes from the stomach and the terminal ileum in this patient. The signal coming from the terminal ileum corresponds to the heterotopic gastric mucosa of a Meckel diverticulum. Observation is usually enough for asymptomatic patients with a Meckel diverticulum. However, if symptoms develop, then the treatment of a Meckel diverticulum is surgical excision. A 2-year-old boy is brought to the physician due to bloody stools for the past 2 days. He also has right lower quadrant pain. Right lower quadrant ultrasound shows a protruding mass near the ileocecal valve. TC pertechnetate scan reveals increased signal from the terminal ileum. What is the most likely pathophysiology of this patient's current condition? This patient presents with bloody stools and right lower quadrant pain. The right lower quadrant ultrasound shows a protruding mass near the ileocecal valve. TC pertechnetate scan reveals an increased signal from the terminal ileum. These findings are consistent with the diagnosis of a Meckel diverticulum. Meckel diverticulum is caused by incomplete resorption of the proximal vitelline duct during the fetal period. Let's move on to Hirschsprung disease. Hirschsprung disease is the absence of Auerbach and Meissner plexuses in the sigmoid, colon, and rectum. Hirschsprung disease can be congenital or acquired. Congenital disease is due to failure of neural crest cell migration to the distal colon. Congenital Hirschsprung disease is due to a loss of function mutation in RET gene and is associated with Down syndrome. Acquired Hirschsprung disease is usually due to Chagas disease caused by Trypanosoma cruzi. Here's an illustration of Hirschsprung disease. Please note the sigmoid colon and rectum are collapsed. This is because there are no nervous plexuses in these segments. Auerbach plexus is necessary to relax the GI tract. Absence of Auerbach plexus results in permanently high pressure in the sigmoid colon and rectum. In contrast, the remainder of the colon has normal innervation. The most distal part of the innervated colon is dilated due to accumulation of fluid and fecal masses. This dilated colonic segment with normal innervation is called the transition zone. Hirschsprung disease typically presents with bilious vomiting and abdominal distension. This is due to proximal colonic dilation. Delayed passage of meconium is the classic presentation of Hirschsprung disease in the newborns. This is because the hypertonic sigmoid colon and rectum do not allow the normal passage of stool. Chronic constipation occurs later in life due to the same mechanism that we have discussed just now. Diagnosis of Hirschsprung disease starts with physical exam. A squirt sign represents the explosive expulsion of feces on digital rectal exam. Rectal manometry will show an increased pressure in the rectum and the sigmoid colon. As we already mentioned, Auerbach plexus is necessary for normal colonic relaxation. Therefore, absence of Auerbach plexus increases interluminal pressure in the aganglionic segments. The definitive diagnosis is made with a rectal suction biopsy. A regular biopsy checks only the mucosa, but a rectal suction biopsy checks the mucosa and submucosa. Suction biopsy is necessary to diagnose Hirschsprung disease because the Meissner plexus is normally located in the submucosa. Absence of the Meissner plexus in the submucosa on rectal suction biopsy will confirm Hirschsprung disease. Management of Hirschsprung disease is surgical resection of the aganglionic segment. A 2-year-old girl with Down syndrome presents with chronic constipation and intermittent bilious vomiting. The physician observes an explosive expulsion of feces on digital rectal exam. Rectal tone is increased on rectal manometry. Abdominal X-ray reveals an enlarged descending colon with a narrow sigmoid colon and rectum, which test can definitively diagnose this patient's condition. This patient with Down syndrome presents with chronic constipation and intermittent bilious vomiting. The physician observes an explosive expulsion of feces on digital rectal exam. Rectal tone is increased on the rectal manometry. Abdominal X-ray reveals an enlarged descending colon with a narrow sigmoid colon and rectum. All these findings suggest the diagnosis of Hirschsprung disease. Hirschsprung disease can be definitively diagnosed with rectal suction biopsy. We'll finish off this lecture by discussing necrotizing enterocolitis. Here's an overview slide of the topics we're going to discuss for necrotizing enterocolitis. Necrotizing enterocolitis, as the name implies, is intestinal inflammation and necrosis in infants. This disease most commonly affects the terminal ileum and cecum. Necrotizing enterocolitis is caused by invasion of GI mucosa by gas-producing bacteria. Invasion, in turn, causes intestinal necrosis. There are 3 well-established risk factors for necrotizing enterocolitis. First, infants with very low birth weight and prematurity are more likely to develop this disease. This is because premature infants with very low birth weight have an immature immune system and insufficient gut colonization with beneficial bacteria. Therefore, the gas-producing bacteria overgrow in the GI tract and penetrate the GI walls. Enteral feeding has also been associated with necrotizing enterocolitis. There are several non-specific signs of necrotizing enterocolitis. The infant may experience apnea, lethargy, and fussiness. Additionally, the baby may have signs of septic shock like hypotension, tachycardia, and fever if bacteria have spread from the GI wall to the blood. Gastrointestinal signs include feeding intolerance and bilious emesis. Additionally, the patient may have abdominal distension and erythema due to colonic dilation. Hematochezia results from bowel necrosis. Necrotizing enterocolitis may be complicated by disseminated intravascular coagulation. This is because spread of bacteria from the GI wall to the blood diffusely activates the coagulation system, inducing DIC. Post-surgical complications include strictures and short bowel syndrome. This is because surgery usually involves resection of large portion of bowel, which leaves the patient with a fibrosed, shorter bowel. We will talk about management of necrotizing enterocolitis later in detail. Diagnosis of necrotizing enterocolitis is established with the abdominal X-ray. The hallmark finding of necrotizing enterocolitis is pneumatosis intestinalis. Pneumatosis intestinalis is the presence of air in the bowel wall. This is because the gas-producing bacteria produce air in the gut wall. Pneumoperitoneum is the presence of air in the peritoneal cavity. It is not always present, but if it's observed on the abdominal X-ray, it indicates bowel rupture. Blood culture should be obtained to screen for sepsis. This is an abdominal X-ray of an infant with necrotizing enterocolitis. Please note the lucent circular areas in the gut wall representing accumulated gas. This is pneumatosis intestinalis. Pneumatosis intestinalis is the hallmark finding for necrotizing enterocolitis. Here you see a chest X-ray showing pneumoperitoneum. Please note the lucent area between the right hemidiaphragm and the liver. This lucent area corresponds to air in the peritoneal cavity, also known as pneumoperitoneum. If this is seen in the setting of necrotizing enterocolitis, it indicates there is bowel rupture present, which is a surgical emergency. Management of necrotizing enterocolitis includes making the infant NPO and nasogastric decompression. Additionally, intravenous fluids should be initiated, followed by empiric antibiotics. There are certain indications for surgery in the patients with necrotizing enterocolitis. First, if the abdominal X-ray shows pneumoperitoneum, this signifies bowel perforation. Therefore, the patient needs emergent surgical resection of the necrotic bowel segments. Additionally, if the patient experiences clinical deterioration despite optimal medical management, he or she should undergo surgery as well. This is because clinical deterioration suggests bowel necrosis. Here's a table summarizing the topics discussed in this lecture. Pause the video and take a moment to review the table. Let's conclude this lecture with a multiple choice question. A 3-week-old boy is brought to the physician due to fussiness and poor feeding. He was born at 34 weeks of gestation with a birth weight of 1 kilogram. His vital signs include a temperature of 39 degrees Celsius, blood pressure of 60/35, heart rate of 175, and respiratory rate of 62. Physical exam reveals diffuse abdominal tenderness with no rigidity. Abdominal x-ray shows gas in the bowel wall, but no air in the peritoneal cavity. He is placed on NPO regimen and he undergoes nasogastric decompression. Which of the following is the best next step in managing this patient? A. IV fluids, B. IV antibiotics, C. Blood culture, or D. Surgery. This patient presents with nonspecific symptoms of fussiness and poor feeding. He was born at 34 weeks of gestation with a birth weight of 1 kilogram. Therefore, he is premature with a very low birth weight. His vital signs reveal fever, hypotension, tachycardia, and tachypnea. Abdominal x-ray shows gas in the bowel wall, but no air in the peritoneal cavity. These findings are consistent with the diagnosis of necrotizing enterocolitis. He is placed on NPO regimen and he undergoes nasogastric decompression. The best next step in the management of this patient is IV fluids to increase blood pressure to the normal range. Therefore, the correct answer is option A. Here's a slide reminding us of the management of necrotizing enterocolitis. Let's discuss why other options are incorrect. Option B, intravenous IV antibiotics, is incorrect because antibiotics are administered after a blood culture is obtained. IV fluids are prioritized to support this patient hemodynamically. Option C, blood culture, is incorrect because it's usually done after IV fluids are initiated. Finally, option D, surgery, is incorrect because it's performed when the patient has pneumoperitoneum or is deteriorating despite medical management. Therefore, one should first try medical management. And that concludes this section.